Very serious.
But somehow you're here, so am I.
Yeah.
Okay, let's get Lagos informed. Management of anemia in sickle cell disorder. Let's start from, the first part of it. What anemia really is all about.
Okay, so anemia basically means, in layman terms, shortage of blood. So usually we tend to characterize anemia based on the sex, age, and geographical location of an individual. So in sickle cell anemia, what happens is that an individual inherits a sickle cell gene from each parent, making that individual an homozygous S. So that means the person is HBSS. Now what happens in sickle cell anemia is that the red cells don't get to live long as they should be. An individual without sickle cell anemia has a red cells lifespan of about 120 days. That's average of about 4 months. But in sickle cell anemia, you're looking about 20 to 30 days, meaning that that individual is in a chronic state of hemolysis. The red cells are always being destroyed, and that individual the bone marrow of that individual has to sort of keep up and keep on working and working just to churn out red cells every hour, every minute, every time to keep up with the level of destruction.
Right.
Yes.
Okay.
So in this kind of state, we realize that individuals with HBSS, they have what we call chronic anemia, and the interesting thing is that they're sort of used to it. Their body has adjusted to this chronic state of anemia, and they can function almost well with a PCV of 18-20%. If you and I have a PCV of 18-20%, we'll probably not be here.
So when you say you and I with the genotype what?
Yeah, AA or
okay.
AS.
All right.
Definitely not SS.
Okay.
So they are used to this chronic state of anemia, and they sort of function, albeit very normally.
How is that possible?
Yes, because of this chronic state of anemia, the body has adjusted to the chronic hypoxia. It's compensated. That's what we call it. We call it a form of compensated anemia, and they can do just fine with it.
Okay, so when you say adjust, which means at the beginning it wasn't so easy.
Yeah, exactly. But
okay, so at the beginning they struggled.
They sort of struggle, but it's a chronic thing. It's not something that just happens.
Okay,
all of a sudden. It develops gradually, and the body just sort of adapts to it. Yes, that's the beauty of nature. That's the beauty of the human body. So what happens is that individual with HBSS, they do quite well, but in situations where this rate of hemolysis is increased. Yes, what happens is that they might not be able to do fine, and then you have to actively manage anemia in such cases.
What do you mean by increased hemolysis?
Yeah, so there are conditions like what we call the hemolytic crisis, the hyperhemolytic crisis. Remember I said that the red blood cells of individuals with HBSS survives about 20 to 30 days as against the normal 120 days. In hyperhemolytic state, they might just survive for 5 to 10 days. So you can imagine that sudden drop in the lifespan of red cells, and hyperhemolytic crisis can be precipitated by infections, by stress, menstruation, excess of temperatures, weather conditions, and increased exercise. Also, individuals with HBSS can develop what we call a plastic crisis. Now, just imagine, and I'm not being traumatic, acquiring a virus that sort of switches off the bone marrow from producing red cells, and then that bone marrow just ceases to produce red cells. Then how do you survive without red cell carrying oxygen around your body? It's almost impossible. And then because of this increased production of red cells, we need the production of red cells involve using, let me call them raw materials, vitamins, folic acids, and all that, because you have to synthesize DNA in these red cells. So in HBSS, in individuals with HBSS, what happens is that they can use up these raw materials, and that there's nothing to make red cells. So this is what we call the megaloblastic arrest or megaloblastic crisis. And also there can also be a sequestration crisis, in which these abnormal red cells get pulled up in the organs of the abdomen, can get pulled up in the spleen, can get pulled up in the liver, and just what you see is just a sudden drop in the red cells. Now, I believe this program is not just to educate medical doctors, also to educate the individuals with sickle cell anemia as well as caregivers. So it's important to note that if you notice things like an increased jaundice in an individual with HBSS, it's a point of concern. Or you notice that increased abdominal girth or increased abdominal swelling in an individual with HBSS, it's a point of emergency, and you need to bring that person to the hospital. You don't wait until the person start manifesting the telltale signs of severe anemia, of decompensated anemia, before you bring them down to the hospital.
You said something about severe jaundice. What we know is that, yes, the white part of the eyes, the color is yellow.
Yellow.
So how do you...
White.
That the white part of the eye turns
yellowish. Jaundice.
Yes. So when it's increased, what happens?
Yes, so it just tells you that that individual is most likely destroying the
what do you
red
see?
cells.
Is it like the yellowish part really
it gets
really
deeper?
Okay, so it's a deeper yellow.
Yes, a deeper yellow than the usual yellow the individuals with HBSS usually have. So you notice that this yellow is getting deeper or is getting green. Then there's a point of that's a source of concern. You don't wait until it now gets so yellow and then the red cells are like almost completely gone before you bring that individual to the hospital. So it's good that caregivers and individuals with HBSS they notice these things fast and present to the hospital before complications
begin.
Setting. Yes.
Okay. 10 minutes gone past the hour of 1 Lagos. 92.3 Inspiration FM is where you're at. Surviving Sickle Cell on your number one family radio in partnership with the Sickle Cell Foundation and of course in honor of the memory of our blessed Tosi Buckner. Thelma Elms is my name. I have Dr. KEMI OTOKITI in the studio, who is a senior registrar, Department of Haematology and Blood Transfusion from LUTH, Lagos, and we have been talking about managing anemia in sickle cell disorder. If you do have certain questions, concerns as a parent or as an individual, as an employee of labor, and you have some fears or concerns regarding this topical issue, you can get through to us on the number 0700 923 923 923. You can also chat us up on our WhatsApp platform on 0817 313 6193. Dr. Otokiti, so I want to ask you, does every patient of a sickle cell disorder stand the risk of anemia?
Yes.
Every single one of them?
Yes. Now, remember when we started the program, I mentioned that they have what we call chronic anemia. They're in a chronic anemic state. Why? Because their red cells are being destroyed faster than normal.
And then you describe the ones who can actually adapt.
Yes, and then they adapt to it.
Okay.
But the problem that happens is when this rate of destruction is now faster than what the bone marrow can compensate for.
Rate of destruction?
Yes.
Okay, you tell us what that is about. Let's take this call. Hello, good afternoon. Do try to call us back. The number again is 0700 923 923 923. Okay, we have another. Hello, are you there? Hello, good afternoon. Oh, we lost you again. Please do try to reach us. Okay, rate of destruction. Rate of destruction. What is that about?
Okay, so in sickle cell anemia, what happens is that this individual is homozygous for HBSS. So the red cells contain the sickle hemoglobin. Now the bad part about the sickle hemoglobin is that they precipitate in the red cell, destroy the shape and architecture of the red cell, giving them that characteristic sickle shape. That's why it's called sickle shape. Like that farm tool called sickle.
Yeah.
Yes, so it gives them the sickle shape. And what happens is that these sickled red cells are rigid, they are not deformable, they can't move through the milieu of the blood vessels very well, they get destroyed. Yes.
All right.
So there's an increased rate of destruction. They don't survive the 120 days that they should. They survive 20 to 30 days. So that's an accelerated rate of destruction.
Okay, so why you say that there are some with time they get to adapt to this difficulty, because it is. Yeah. However, easy you try to make it sound, and then it gets to a point where it has passed really. Like, be careful. When at what point should we, is one able to identify, either as a parent or someone or a caregiver who actually has a sickle cell patient in front of them, know that, okay, yes, this child actually has anemia, but now it's become a problem. What are we looking for? What signs? Are there, like, inflammations on the body, that symptoms that we can find on the body?
Yeah, very good question. So it's very important and it's germane that caregivers of individuals with HBSS and also individuals with HBSS, they know what is called their steady state. It's important.
Steady state.
PCV. So this is the PCV that they have when there's no problem, when they are fine, when there's nothing amiss.
And you say your PCV can be as low as 18%.
It can be as low as 16, as 15%.
And they're okay.
And they're fine.
Okay, but looking at a child, maybe except you as a doctor, I cannot tell that this child's PCV has dropped way, way beyond the steady state of 16%.
Yes.
So what should my eye meet?
Okay, so things like the worsening symptoms, like they can't go about the usual daily activities. Yes, they can go about their usual daily activities. They're sick, they're weak, increased fatigue, and of course worsening jaundice and what we call prostrations. They just want to lie down. They're really sickly feeling. And now what happens is that, in fact, medical doctors also are guilty of this. You see an individual with a PCV of 16% or 18%, we should not be too quick to transfuse and say, oh, this PCV is severe, this is a severe anemia. If that's the steady state of that individual, that's fine.
So how is the doctor able to tell the steady state?
So that's why it's good that individuals with HBSS know their steady state. So if an individual with a PCV of 18 comes to me, and I know that the steady state is, for example, is 2021, I'm not going to rush to transfuse.
So by steady state, what you mean is the person is acting normally? Yeah,
the PCV when there is no problem. The PCV they usually have when there is no problem. Yes, so it's important that they have to know. You don't just know at one reading. Constant checking. And so, okay, so the PCV of this individual is usually 2021, so that's your steady state.
Steady state.
So if it drops down to a certain level, I know I have to act. Yes.
So how often should one with a sickle cell disorder check in so that the doctor is able to, have a record of, yes, this is the steady state of this patient?
Really, there's no particular time interval. It's just that once they come to you for their routine cleaning, for example, they come with a PCV, and then you just get to know over time that this is the person's or individual's steady state. Yeah.
Okay, let's go to the phone lines. The number again is 0700 923 923 923. Who's out there? Hello, are you there?
Hello, good morning.
Good afternoon. It's past 1. Sickle cell disorder, die as young as 16, or was it 18 that he said?
I think he said 18.
Okay, and the answer to that is no. It's a
no.
big no.
It's a myth.
It's a big no.
It's not true.
Okay.
Yes. Of course. Being an individual with sickle cell is attendant risk and complications, but with a good lifestyle modification, good medical care and all that, yes, they can live as long as possible, and they can live a almost normal life.
Okay, so beyond medical care, which yes is really important, lifestyle seems to be of primary concern.
Very important.
So which is what I think wisdom wants to know. Okay. What do I tell this individual who's before me that obviously he loves so much that he wants to keep alive? What should I tell the person? This is what you need to do, or this is what you do not need to do.
Okay, one of the most important things is that early diagnosis. Yes, early diagnosis is important. So from early diagnosis, things like influencing the type of immunization they have. They just don't go through the normal NPI immunization. They have to go the extra mile. And also penicillin prophylaxis and all that, antibiotic use, early institution of antibiotic use in the setting of fever, avoiding things like extremes of temperature, use of something as simple as folic acid, good water intake goes a long way in influencing how
a lot of water.
Yes, a lot of water. Just folic acid, eating good foods, fruits, and all that. Yes, paludrin, malaria prophylaxis and prevention goes a long way.
Okay.
Do you have a call?
Yes, but we kind of lost it. Let's see if we can take this one. Okay, we lost you too. The number again is 0700 923 923 923. Hello, who's out there? Good afternoon.
Hello. The guy wisdom.
Yes.
That when people live to 18, they die. They have their sickle cell patients. Well, it's really a myth to be sincere. The truth is, people can die from any sort of sickness before 18 or at any point in time. I am a sickle cell carrier.
Okay.
or patient, or whatever you choose to call it.
Mm-hmm.
And to the glory of God, I am 47.
Wow.
Yeah.
Glory to God. Mm-hmm.
Yeah, glory to God. And I know growing up was a bit challenging, and for a number of years, I had to be going to the clinic, Professor Keoju's clinic at LUTH,
Mm.
so all those specific things, yes, I agree. But the truth is, even now, I don't know what my steady state is. I don't fall ill anymore, thank God.
Yeah.
But I had a crisis 2 years ago. It was a bit frightful for me. I guess it was from the job because my job is so stressful.
Mm-hmm.
But the truth is, I live a normal life. And I know it's not by anything I'm able to do or not do.
Mm-hmm.
It's simply because of the grace of God.
Right. Thank you so much, Bolale, for sharing with us. That was a beautiful one. Let's take one more call. And okay, I think that's my cue. I should take this break. Lagos, we'll be right back. Still surviving sickle cell. Surviving sickle cell on your number one family radio, 92.3 Inspiration. Don't go away. We'll be back. Minutes before we wrap up the show is still surviving sickle cell on your number one family radio with Thelma Illems and Dr. KEMI OTOKITI, a senior registrar from the Department of Haematology and Blood Transfusion, Lagos University Teaching Hospital, LUTH. Management of anemia in sickle cell disorder is what we have been talking about, and we have started, with what anemia is, which is mostly shortage of blood. The fact, most surprisingly, like I always say, there's always one revelation or the other, and I'm not sure how that actually works, but I think I'd like to go with Bolande, who says it's just, all the grace of God. It's the grace of God that people have shortage of blood and yet are able to thrive and yet are able to live, and then they have something called the steady state, but until it goes off that mark and then it becomes chronic. Hence, you have to take into consideration managing that state, that is managing anemia in sickle cell disorder. What do we need to know when it comes to management of anemia in sickle cell disorder, Doctor?
Okay, so one of the primary things to do in the setting of decompensated anemia in HBSS, and when we have to do something about it, is that you want to tackle first the precipitating factor.
What's that?
Yeah, so part of it can be infection.
Mm-hmm.
So as I said earlier on, in HBSS they have this chronic state of anemia, and they do just fine. But for whatever reason, if the specificity drops down to critical levels and they can't function and the bone marrow can compensate, you have to manage the underlying or precipitating factor, be it infection or whatever it is it extremes of weather and all that. Then also things like erythropoietin. Now, erythropoietin is a growth hormone that drives the production of red blood cells by the bone marrow. So in sickle cell anemia, what happens is that their kidney, this erythropoietin is produced by the kidneys, and in sickle cell anemia, they have what we call the sickle cell nephropathy, meaning that their kidneys sometimes don't function as normal and might not be able to produce this erythropoietin. So simply giving erythropoietin might just be enough to drive the bone marrow to produce enough red cells, and then the anemia is cured. And also double dose hematinic. So usually give folic acid 5 milligrams per day, but increasing it or tripling the dosage might also help in tackling the anemia. And then the last but not the least, transfusion of red blood cells. I'm putting that low because transfusion comes with its own attendant risk, and understanding that this individual with sickle cell will most likely need blood, is in a chronic anemic state, and most likely will need blood over and over
to function.
You don't want to sort of make that your first point of management, your first point of treatment in managing them, because then if you keep on giving blood, there's risks of iron overload, risks of transfusion of transmissible infections like HIV, hepatitis B and C, syphilis,
and that's another
malaria.
situation.
That's
altogether.
another situation we don't even want to. There's a risk of alloimmunization and sensitization and all that. So it's something we usually keep for special situations. Yes, in managing anemia in sickle cell, but transfusion is also a treatment modality.
Okay, so if I get you correctly, the very first thing that should come to mind is tackling what probably triggered it to that extent,
yes.
which could actually be infection, or
being
exposed to
extreme
weather conditions.
And also use of the raw materials, like I said, folic acid and all that, megaloblastic arrest or megaloblastic crisis. So just giving that folic acid might just be enough to stimulate red cell production and treat the anemia.
Okay, we're going to take our very last call on the show. Hello, good afternoon. Okay, we lost you there. And on that note, we gotta go. Thank you so much,
Thank
Dr.
you.
KEMI OTOKITI, a senior registrar in the Department of Haematology and Blood Transfusion from the Lagos University Teaching Hospital, LUTH. The Sickle Cell Foundation, from which we're in partnership with on the show, is located at Igaraba, Surulere, just right opposite LUTH.
Yeah.
Yes, hence the likes of Dr. Tikiti. Once in a while, they come here in the studio to help us enjoy their wealth of experience. I want to say a very big thank you so very much for doing this. Yeah. Join us same time, Lagos, same day, same station. That's what, 92.3 Inspiration FM, Saturday, 1 p.m. for yet another interesting edition. My name's Thelma Illams. Have yourself a warm Saturday, I would say. Keep warm. I'll be back on Monday on the tea break at 11 o'clock. Bye for now.